Hi, everyone, and welcome to the next edition of the Academy by Acclivity Health Solutions. I'm Jeremy Powell, CEO and one of the co-founders here at Acclivity. And today we're going to jump into what should your administrative focuses be inside of any kind of value-based care contracting. And so, again, your contract will drive some of your behavior, but there's some basic building blocks that you have to have in place. I'm going to borrow liberally from a good friend of mine who had the opportunity to speak at MGMA about how to do this. And so I think some of the compelling parts that Lindsay Allen made in that discussion was really first focus on understanding the structure of your team, how to staff that team, and how to ensure you're measuring the department's value. So she went through, and I'm going to do a little bit of it here. She went through what each of these roles are, how they're staffed, and in sort of what way do they play. So the beige colored persons in their world are medical assistants. They do have LPN support. Their social care coordinators are not licensed social workers in their world. They're actually four-year degree sociology and psychology bachelor holders. And so this was a way for them to provide support administratively without needing the ability to sort of bill social worker rates for any service. And so again, you'll see that these folks are clinical in nature. They're driving very specific sort of functions. And then at the top of the org is the leaders as they are under sort of analytics and quality management and measurement. So again, data and technology become really important even in the team and how you structure that team. You need to be able to clearly articulate what the responsibilities are. So those medical assistants are doing chart prep and transitional care management. So this would be real understanding about how to raise concerns whenever a person's coming into clinic or a person's being seen as part of an impaneled, providers panel, how to help them see the important patient journeys that they need to be aware of in either a chart prep fashion or a daily huddle fashion. And then when someone does something unexpected, like an emergency or hospitalization event occurs, how do you get them back into clinic or back under care? All of the organization has to think about risk adjustment, really being able to code for opportunities to raise benchmark becomes important, really being able to pay attention to the sickest 10% in their case. We see at least 5% is the floor. 5% of your patients will consume 50% of the spend. So if you're not coding them appropriately, you're really going to fall behind on the ability to make money. And then lastly, like I said, these are not licensed social worker employees or staff. They're four-year degreed in sociology and psychology, and they really are working this model, looking for opportunities to engage in an administrative way and engage differently than their original model of care was previously before getting into a lot of the alternative payment models. So some of the objectives that we're just calling out here have lessons learned. So what did they learn? Break your work down into things that have to happen in a repeated fashion. Know what needs to be done daily, weekly, monthly, and quarterly. Prioritize your contracts that have the most benefit for you. And then do green actions. Green actions are the things that are going to create revenue for the business. For other parts of your organization, make sure you're consistently thinking about your staffing ratios. So in their world, they thought a full-time employee, assuming one coordinator could support between 750 and 1,000 patients. Your mileage may vary depending upon the type of practice you are, where you practice, what your patient population looks like, et cetera. So be mindful of and watchful of how you're doing relative staffing ratios and performing against those staffing ratios. The other thing you need to be able to ensure that you can do is to cover the investment you're going to have to make. These programs often don't pay out for the first 18 months. So think of a Medicare Shared Savings ACO as an example. You're making fee-for-service as you normally do throughout the first year. You finish your first year and you don't get your actual check until August of the following year. So that's that 18-month funding lag. So they're consistently aware of how do they communicate value out to their leadership and doing things to offset the lag. They created annual wellness visit programming. They implemented chronic care management, the 99490 and other codes to really be able to offset cost. And then really work on figuring out how to contract better for you to get the data you need in contracts as an explicit thing that the payer is going to give you. Request carve-outs where appropriate. Make sure that you're asking for anything they can do to prepay. Like all of those things are the potential ways that you can offset the investment you're going to have to make. The next objective to focus on is the administrative focus for you all is to get our technology and data foundational components laid out. So they thought through thoughtfully what technology were they going to deploy across the electronic health record? What were they going to do to ensure they had care management focused in the engagement between visits? And then how are they going to report financial and clinical data up to leadership in a way that could be consumed and where adjustments could be made through command and control from that visualization and clarity? How can they adjust model of care? How can they adjust staffing, et cetera? So the things they looked at on the data side was, how do I get claims and scheduling data out of my own system? How do I get data from the portals that are available to me from all my payers? How do I find out what I can get from information related to how payment has been made? And then what can my community or region supply for event notifications, think admission, discharge, transfer, or health information exchanges? In their world, what they ended up building with us 6 years ago or so is an infrastructure that allowed for us to really be able to connect all of their managed or delegated risk contracts, the community health information exchange detail, all of their affiliated practice management and electronic health records, and then data directly from Medicare, where they're playing inside of Medicare Shared Savings and primary care first in the state of Florida. Those things come together, and what they learned about that is you have to really automate as much as you can. You must really focus on getting things that'll make workflow easy, like scheduling data so you can do point of care clinical decision support. Queues need to be built, and then those medical assistants need to be able to work every day. You have to be able to clean up anything that's going to be point of care facing, because a cognitive load that's too much, they'll fatigue from it. So understand who you're working with, whether it's a medical assistant and sort of the day-to-day work inside of your care management platform, or your providers at the point of care. They cannot get overwhelmed. The second thing you need to be able to focus on is really prioritizing what might look like low-hanging fruit. So some of the things they called out were risk coding opportunities. Look at how the HCCs are coming out. If there are new ones that really would impact you, deploy a practice of improving your care coordination and coding efforts to match to those new HCCs that might benefit your panel. Look inside of things that you already are coding for upcode opportunities, since she was calling out specific types of medications. Really watch your patients that have 2 or more emergency visits in a 12-month period, and really look to use the community where possible for your advanced illness care, where we can see $18,000 to $40,000 of savings per patient per year when they're in the very last corridor of life. And then lastly, what you should be focused on is, how are you doing? If you remember, these organizations, when they jump into their first foray of value-based care, have an 18-month lag. This should be your trend. You should see up and to the right across all the things that matter relative to your revenue impact. And this is an example of her and her organization and how they did in the first 5 years of that work. Looking forward to any next comments you might make. As always, send them to info@acclivityhealth.com. Talk to you soon.